Good afternoon, everyone, and welcome to this presentation on perspectives in Graves' disease management. This presentation is being sponsored by Immunovant. I'm Pete Salzman, the CEO of Immunovant, and I just wanted to highlight one point about Immunovant. In the center of the slide, you see what we do. We are developing a targeted therapy that has the ability to reduce autoantibodies and therefore may have relevance to Graves' disease. Therefore, we have an interest in promoting education of Graves' disease, both in terms of the pathophysiology as well as the unmet need. I'm really excited today to be joined by two experts in the treatment and evaluation and research of thyroid disease. You see them on the screen with me as well as on the slide. First, I'd like to introduce Dr. Giuseppe Barbacino. Dr. Barbacino is an assistant professor of medicine at Harvard Medical School and associate physician at Massachusetts General Hospital in Boston. He graduated from medical school at the Catholic University of Sacred Heart in Rome. He has completed his postgraduate training at the University of Pisa, Italy, at the Mount Sinai School of Medicine in New York, and at the University of Massachusetts Medical School in Worcester. Dr. Barbacino's research interests have been directed to the understanding of the genetics of thyroid autoimmune disease and clinical aspects of thyroid cancer. He is now primarily involved in the care of patients with thyroid eye disease, hyperthyroidism, thyroid nodules, and thyroid cancer. He's also involved in the teaching of medical students, residents, and fellows within the Harvard Medical School system. Dr. Barbacino is board certified in endocrinology. I'm also joined today by Dr. Mark Lupo. Dr. Lupo is the founder and medical director of the Thyroid and Endocrine Center of Florida, located in Sarasota, and is a clinical assistant professor at Florida State University College of Medicine. He attended Duke University as an undergraduate and then received his medical degree and internal medicine training at the University of Florida. He completed an endocrine fellowship through a combined program at UC San Diego and Scripps Clinic. His endocrine practice is limited to the thyroid, with an emphasis on structural thyroid disease, nodules, and cancer, as well as autoimmune thyroid disease. The Thyroid and Endocrine Center has been involved in several clinical trials on thyroid nodule evaluation, autoimmune thyroid disease, and laboratory testing. He is on the faculty of the Florida State University College of Medicine as clinical assistant professor. Dr. Lupo is also board certified in endocrinology. Our learning objectives today are to review the immunologic pathways resulting in Graves' disease, describe both the benefits and some of the limitations of current therapies, and discuss some patient-specific considerations that may inform the treatment of Graves' disease, both with current standard of care as well as potential future options. Great, we're going to begin with this poll question. Excellent. I think that gives us a good picture for those of you who weren't able to follow that as we quickly scan through. The range of answers goes from about 5% up to 60%. And I guess that's not surprising given that we didn't define exactly what difficult to treat means. That probably means different things for different physicians based on their practice setting and other factors. And Graves' disease is certainly a complex condition, as we'll get into today, and it's not surprising to see a range of answers there. So now I'm going to turn it over to Mark, who's going to review on the next slide the pathophysiology of Graves' disease, and then I will turn it over to Giuseppe to talk a little bit about the current treatment paradigm. Mark?
Thank you, Pete. Appreciate that. So I'd like to just review the pathogenesis of Graves' disease. We know that Graves' disease is an autoimmune disease, and it's driven by pathogenic IgG antibodies that stimulate the TSH receptor. But let's dig a little deeper in terms of how this works. So usually we enjoy self-tolerance. Self-tolerance means that if our body produces an antigen, we recognize it as from our body and we don't react to it. But sometimes this self-tolerance breaks down and we lose self-tolerance. For example, when the thyroid gland, there's peptides, TSH receptor peptides that are continuous being released. Most of us can ignore those pretty well, but if they get assimilated by an antigen presenting cell, then in the context of a class 2 MHC, this antigen, this TSH receptor antigen, could then be presented to the immune system, and that causes a cascade of problems. So these antigen presenting cells, which are primarily local dendritic cells, B cells, and also macrophages, start the process. But interestingly, there's research that shows that the thyroid cells, also with the MHC class 2, can become antigen presenting cells once that autoimmune attack has started. So when that attack starts, it's perpetuated locally by the classic inflammatory immune system cells, and then even driven by thyroid cells that become APCs presenting TSH receptor peptide to T cells. So T cells then are essentially activated. And when they're activated, they upregulate production of CDL40 CD840 ligand, and then it's co-stimulated with CD40 on B cells that increases the B cell proliferation and activity. So then these B cells can differentiate into plasma cells. So it's the plasma cell that then produces the TSH receptor antibodies. And these TSH receptor antibodies are the underlying pathophysiologic driver of Graves' disease. They bind to the TSH receptor on the thyroid cell, and that causes the clinical manifestations that we see, namely increase in T4 and T3 production, which is the thyrotoxicosis, and secondly, thyroid cell proliferation, which causes the diffuse goiter. So this is the underpinning of Graves' disease, which is clearly an autoimmune disease driven by these pathogenic IgG antibodies that stimulate the TSH receptor the TSH receptor.
Thanks, Mark. That's a great overview of the foundational pathogenesis. Giuseppe, maybe you could talk about the three primary treatment options in managing Graves' disease that physicians have at their disposal today.
Yes, Pete, thank you very much. And thank you, Mark, also for your very concise but complete description of the pathogenesis. So we have had treatment for Graves' disease for many decades, and we have used those treatments for a long time, and we know a lot about them. They're effective, but they have glitches. Nowadays, we tend to prefer anti-thyroid drugs for a number of reasons that we don't have time to go over with, but it has become really the preferred medicine. These are methimazole and PTU, and what they do, they block the production of thyroid hormone from the thyroid gland. They basically put a brake on the thyroid hormone production mechanism so that the person from hyperthyroid hopefully will become euthyroid and see their symptoms improve. They're very effective, but they have potential side effects. Methimazole and PTU can cause minor side effects that are fairly common. 10 to 5% of people will get a rash, they'll get joint pains, they'll get a bad taste in their mouths, and that's what I counsel patients about when I describe the options to them. Some people will rarely get a more severe side effects. For example, agranulocytosis, which is a potentially lethal complication of methimazole, is seen in about 1 person in 500 or 1 person in 200, depending on what statistics you look at. It's uncommon, but it scares people sometimes. And people wonder, am I immunocompromised? What happens if I get the flu? There is always that concern. And then there is liver disease that is rare, but also significant when it happens. One problem that I face often with these drugs in the younger female population is the fact that they can be associated with malformations in the fetus when administered during pregnancy. And so that's a major obstacle in women who are in the reproductive age. Then there are people who will not respond to methimazole, whether they don't respond because they don't take it, they don't want to take it, or they don't respond because some people are more resistant than others. It's hard to establish, but it is true that not all people will experience a satisfactory response to methimazole. The other treatments involve destruction of the thyroid gland, and you can do that with a knife. Surgery is very effective. The next day you are cured. And it has been done very effectively by very experienced surgeons nowadays. It still carries the risk of recurrent laryngeal nerve damage with consequence hoarseness that we accept sometimes when surgery is done for thyroid cancer, deadly disease sometimes, but it's hard to accept it when you do it for a benign condition. Some people get hypocalcemia from hypoparathyroidism. And so there are concerns that we have to explain our patients and make them hesitant sometimes in choosing this. Radioactive iodine doesn't do any of that. It does destroy the gland in a very silent way. It destroys it slowly over a period of weeks or months, but it does carry the risk of causing thyroid eye disease or worsening thyroid eye disease. And that's often a non-starter. When you start a conversation with a person who is concerned about their hyperthyroidism, you tell them you can get radioactive iodine and maybe your eyes will bulge. It is often, and that's why radioactive iodine is really rapidly fading. Although there are still patients who select it. The other important thing to remember about these two different treatment options is that they do cause permanent hypothyroidism. And although we do recognize that in the vast majority of people, hypothyroidism can be easily treated with levothyroxine, which is a safe medication, there are a number of people that are somehow unhappy with the treatment, either because they don't feel well, the same level of energy that they had before the thyroid ablation or thyroidectomy, or because they gain weight. There is a lot of studies being run about whether this is really caused by the hypothyroidism or not. But suffice to say that people are very hesitant sometimes to choose any of these two treatments. And so these are the sort of glitches we find of. And part of that is related to the fact that all of these treatments, what they do, they punish the victim and not the perpetrator. And that's the problem that we're facing. We are killing the victim, which is the thyroid, and not treating the immune system, which is really the reason why we have the Graves' disease. And that's where we expect some development in the future.
Yeah, that's a great summary, Giuseppe, and I like the punchline at the end that essentially the treatment modalities that you outlined, antithyroid drugs, surgery, and radiation, they're all targeted towards the top half of this slide versus the bottom half, where the bottom half is what's actually driving the disease. Excellent. So if we go forward now, in order to get a better perspective regarding the percentage of patients that are difficult to treat as defined by challenges in reaching a euthyroid state. There's many different ways that you could define difficult to treat, but we started with that one. We conducted a chart audit of patients in endocrinology practices, and I'm going to review that in a second. Great. So I just want to draw your attention to a few process elements of this chart review. And in the lower right-hand side of the slide, you'll see that this was a randomized selection of over 1,000 charts at more than 100 endocrinology practices. Those endocrinology practices were across the country in different geographic regions, some urban, some rural, and in each practice, a random selection of patients' charts were chosen so that there was no selection bias on anyone's part. In order for a chart to be selected, it had to meet the criteria in the bullets. Essentially, patient had Graves' disease and had been under the care of the physician as defined in the bullets. Of those 1,120 charts, in the center, there is a pie chart of 998 patient charts. The difference is those patients who already had received definitive therapy, in other words, radioablation or surgery, were removed. So this roughly 1,000 patients in the middle represents those patients who had not received a radioablation or surgery. And in looking through their charts, you can see that about 60% of them achieved a euthyroid state with relative ease. Some visits and some titration, but nothing that was apparent to the reviewers as challenging. On the other side of the spectrum, there were 23% of these 1,000 patients, so more almost 230 patients, who actually never became fully euthyroid throughout the course of their treatment. And then in the middle, there were 16% of patients who did become euthyroid, but it was with a lot of challenges. There was a lot of titration, or they became euthyroid and then lost that state over the course of their condition, so they relapsed. The other thing that was interesting was how patients responded to a physician recommendation to receive definitive therapy. As you may know, the use of definitive therapy has gone down for many of the reasons that Giuseppe outlined. There are complications associated with radiation and surgery, and in particular, the use of radioablation has gone down a lot, as Giuseppe mentioned. Why is that happening? It appears that a lot of the reason relates to patients' hesitation for that therapy. So this pie chart represents nearly 600 patients who received a recommendation documented in their chart at some point to undergo radioablation or surgery. And you can see that of those 600 patients who had were more likely those who are difficult to treat, resulting in that recommendation from their physician, only 40% of them underwent radioablation and surgery. 26% had sort of a documented hard line in the sand that they weren't going to get radioablation or surgery under sort of any condition. And then there were another third, 32%, who were considering the pros and cons as presented by their physician, but hadn't made a decision yet. And in many cases, those people who were still considering definitive therapy, that was something that persisted over many visits. It wasn't like they were just thinking for a visit or two. They contemplated for quite a while whether or not to accept this recommendation. Great. So now we're going to talk about those patients with a little bit of a focus in the middle, those patients who struggle to achieve success. And maybe I'll start, Mark, with you with the question of asking you, how do you define success actually for treatment with an anti-thyroid drug?
Thank you, Pete. Yes, and I agree with Giuseppe's outline, and that's been our experience as well, is that we're seeing a lot of backlash from patients who don't want definitive treatment. So we categorically use first-line anti-thyroid drugs, and I think a good response to that is typically remembering that we want to usually treat for 12 to 18 months. Sometimes treatment is stopped short, and it's stopped short. Even with negative TSH receptor antibodies, the risk of recurrence is a little bit higher than if you go that 12 to 18 month time frame as recommended by current guidelines. So one, we want to render them euthyroid and continuously taper the dose of anti-thyroid drugs to keep initially T4 and T3 in the normal range, then TSH comes up and becomes reliable. But importantly, on low-dose anti-thyroid drugs, we want to make sure the TSH receptor antibodies are negative. I like to see 2 consecutive negative TRAb levels with normal TSH before stopping, and at least 12 months of therapy. So I think that would be successful treatment with anti-thyroid drugs, and I think we get that. And the pictogram here of 5 out of 10 of these representative people, that's probably 40 to 50% of patients who achieve euthyroid, and then we will pull them off anti-thyroid drugs during that 12 to 18 month period.
Excellent. Giuseppe, anything to add there, or how do you define success with an anti-thyroid drug in your practice?
I think that what Mark said applies to my practice. My goal is to make them very clearly euthyroid, which means with a normal TSH. Sometimes, very rarely, I also use levothyroxine when 1 dose of methimazole is too much and 1 is too little. I do that. I try to avoid it when I can. And so there are ways to be creative when anti-thyroid drugs don't immediately hit the spot. I always, talk to them about adherence because it's very important to understand that complete adherence is necessary. You stop methimazole for a week, and then you restart it before you see the doctor, and you're still hyperthyroid, so well, I'm taking it. You haven't taken it for 2 weeks ago. The whole production of thyroid hormone came back, and now you're going to be hyperthyroid for another 4 or 6 weeks, and that's sometimes reasons for failure. So I go over those tricks with the patient to make sure that we understand. But I do agree that there are a number of people who will not achieve hyperthyroidism or will not be able to maintain it.
Yeah, yeah. And you hinted at this already with a couple of sort of anecdotes there, but just generally speaking, who do you find, Giuseppe, are the most challenging patients to achieve success with anti-thyroid drugs? And
yeah, so in my mind, there are some related to social environments. For example, teenagers. Very hard to keep them on a medication, and they are just impossible for them. And they have different, first of all, they're less symptomatic, but also they have a hard time. They're so busy. They have to work hard. They study. They go. So that's one group in which is particularly difficult. And there are people in whom the pathophysiology is difficult. And those are most often people who start with the highest T4 levels, especially with the largest possible goiter. And people with severe thyroid eye disease tend to have a more severe form of the disease, in which antithyroid drugs tend to be less effective. So those are the two groups in which I have more difficulties in general. Of course, there are other instances.
yeah, yeah, that's any groups you would add there, Mark? Are there some other challenging patient categories?
I agree with the adherence to therapy issue. Sometimes people have, lost weight, they're happy with that. They start gaining weight, then they cut back on their methimazole dose. Obviously, challenges with the adverse reactions that Giuseppe outlined in the beginning. And then sometimes it's just not predictable. It's truly a roller coaster of you make a small adjustment and then they're hypothyroid or vice versa. And those can be challenging as well. So, and then the patients with the highest TSH receptor antibodies that are very high at the beginning tend to have a lower remission or response rate. And those who smoke tobacco or exposed to secondhand smoke, that's another red flag potentially for both thyroid eye disease risk and for response to anti-thyroid drugs.
So what I'm hearing from both of you is there are some patients where you can predict in advance they're likely to be challenging, either because of their social situation or just kind of their age, younger, those kind of things. There's other patients whose characteristics, lab tests or on physical exam, suggest to you that this is a patient who's probably going to be harder to get under control. And then it sounds like there's a third category that's tricky because they vacillate and maybe you get them in control and then you're surprised, if I understood you right, Mark, that a couple weeks or a couple months later at a visit they're out of control and you don't think it's because of compliance. Did I get that part right, that there's a third category there?
I think yes, correct. That's I see that happen. We had one today that was completely surprised us in terms of levels going the opposite direction. Yes.
Yeah, we saw that in the in the chart review too, substantiates what you're both saying there, where we had the advantage of looking at this charts over time for many patients, and while there certainly were some patients where the chart suggested there was a compliance issue leading to a lot of up and down, there were others who just seemed to be challenging to manage. Giuseppe, you mentioned the patient who's kind of sits between two methimazole doses. Are you thinking about what's the difference between a methimazole dose? Because I know that there's different ways that people use it. Some people recommend cutting tablets, things like that.
Yeah, so that's inexplicable. But there are, like there is brittle diabetes for which a certain dose of insulin is too much and the next one is too low. There are patients in whom one dose of methimazole, let's say 5 milligrams, is too much and 2.5 is too little. And so they become hyperthyroid if you try to cut back just a minuscule dose. And so those are the patients that I haven't figured out what is the pathophysiology there, but they do occur, they do happen, and I do sometimes treat them with levothyroxine. And in those cases, I put at a higher dose of methimazole so that I'm sure that there's no chance of the hyperthyroidism to return. and then I treat them like with replacement. Of course, they're not happy about that. They have to take two prescriptions. And at the back of my mind, I'm always concerned that if they forget to take the methimazole and they become hyperthyroid again, on top of that, they're also going to have the levothyroxine. And so their hyperthyroidism may become actually more severe because of that. So it's certainly not optimal, and I use it as little as I can, but there are a few cases in which I do.
Yeah, yeah. And those more difficult patients, we know that it's challenging for patients to see a endocrinologist, let alone a thyroid specialist, which are even less common. It sounds like somebody like that would need to be seen relatively frequently. Mark, how often, when you have somebody who you're already sure they're difficult to treat, or they're, very early in their treatment cycle with you, how often are you evaluating patients?
Right. So in the beginning, when someone's symptomatic thyrotoxic, I will see them every 4 weeks until I think things are improving, maybe 4 to 6 weeks. And then we start spreading it out to 2 to 3 months and 3 to 4 months, et cetera. Most of these patients on anti-thyroid drugs, I'm still seeing, at least 3 times a year, sometimes twice a year if they're long term. And often though, what the story they're telling me when they come from the community, if I'm their second opinion endocrinologist, is that the levels were checked only every 3 to 4 months. So they had a lot of time between dose adjustments, so they were becoming hypothyroid, and no one knew it. So I think it's important to be able to or important to recognize that, especially in that first 6 months for most of these patients, you need to really check frequently, often every 4 to 6 weeks, and make sure you make small changes to render them euthyroid.
Yeah. And Giuseppe was mentioning people who change their dose for whatever reason. They forget to take a dose, or they sort of deliberately change it. I think you mentioned to me one point, Mark, that you explicitly counsel patients at the beginning to not do that, among some other things. Is that right?
Yeah, that's correct. We have a anti-thyroid drug or methimazole agreement form that we go over with the patient that, this is a drug that is, has some benefit, but also some toxicity, and that it requires close titration and a collaboration together. So they have to sign off on that. And so if they're not, conforming to that, we certainly give them, first strike, second strike, but eventually we sometimes have to part ways if they're undermining the care too much, which is difficult. But we try to have that clear understanding from the beginning, also highlighting the major adverse reactions that we see. So if they have a fever, to let us know. If they have any symptoms of liver disease, let us know in between visits. So I think that sort of sets the stage and has been helpful since we started that program.
Yeah. Are you doing something similar, Giuseppe? I'm guessing you probably also have very specific instructions for your patients at the
Yeah,
beginning of
so I
care.
do. So I don't have a formal agreement, but I do tell them that if they stop the medicine without a good reason, their hypertension most likely will return rapidly, and that will be another 6 weeks before you can get it over with. And I do explain the pathophysiology, and then I'm very careful in describing the side effects and the warning signs for which they need to call me. I tell them clearly they have a high fever and a sore throat. First thing, they stop the methimazole without asking anyone, and then they call me to get a white count checked. Um, the I do also give them printed material. They can, and I tell them, hang this on your fridge so that if you forget what I just told you, you can go back and read it. But it's very important, and it's better one more phone call than one less. I've had a few cases with the granulocytosis, and thank God they were caught early. I had a few cases also with liver disease, and also they were caught early. But it's a potentially dangerous, rare, but potentially very dangerous condition, especially in the elderly. And it's been shown in studies that the elderly with granulocytosis have a much higher mortality rate than young people.
Yeah, excellent. Great. Well, sometimes there's nothing like a case study to bring to life some of these ideas with a real specific case. So, Mark, I think you're up first to describe a patient with Graves' disease that had some difficulties.
Yeah, thank you, Pete. Yeah, this is a patient I met earlier this year in February, and she had in Florida, and it's probably in other states, you can order your own lab tests. If you have symptoms, you just look at the menu, you check it off, and you and you can order your own test. So she had done this, 52-year-old female had done this because she thought she was going through menopause. She had a fairly rapid weight loss of 22 pounds in a short period of time, 3 months. She was shaky, couldn't sit still, rapid heart rate, heat intolerance. She couldn't sleep, a lot of irritability. So she was, really didn't feel well. And then she, brought these to our attention saying, I need help. I obviously have a thyroid problem. So when I saw her, she had a visibly enlarged thyroid. You could, easily see it walking in the room. She was relatively thin. She wouldn't sit still. She was pacing the room. Heart rate was 120, 130 at rest. She's, tearful, anxious, kind of, can't really focus on anything. That typical stare of hyperthyroidism, but no exophthalmos. She has slight scleral injection, but no overt thyroid eye disease at that point. So lab values are very concerning. She had a free T4 of 6.3, which is 3.5 times upper limit normal, but that free T3 was greater than 20. I mean, that's more than the upper limit of normal. That's a big red flag. Obviously, TSH was undetectable, and we were able to get a TSH receptor binding antibody, TBII, fairly quickly, and that was greater than 40. Normal is less than 2. So, very typical. Put an ultrasound on her like we usually do, and you can see this, Graves' Inferno, diffusely enlarged 50-gram goiter, no nodule, very vascular. So it's very straightforward diagnosis of Graves' disease. But because of her, presentation and her very high T3, I usually don't start 30 milligrams of methimazole, but in her, I thought I need to get rapid control over this. So 30 milligrams methimazole and 20 milligrams 3 times a day of propranolol. And then we saw her back 4 weeks later. And so she had a quicker response than I might have thought. So her free T4 was low normal, T3 normal, TSH, of course, still undetectable. So good reminder to not pay attention to TSH until it's detectable. She had felt better. She'd gained about 7 pounds. She was starting to have a little bit of achiness and tired eyes, but still no proptosis or diplopia or any significant thyroid eye disease. So at that point, we decreased her to 20 milligrams of methimazole and started weaning her propranolol just to use on an as-needed basis. And this is where the unpredictable part, at least I thought, she had called saying, I think my goiter is getting bigger, so I need more of this methimazole. And so I said, we need labs. I can't just go on that. So we need data. So her free T4 is 0.2. Free T3 is low at 1.8. Her TSH is actually a little bit detectable. So I was surprised. This was more of a bigger drop than I would have expected, giving her initial presentation. Still on a moderately high dose of methimazole 20. I said, let's hold it for a week, just to kind of let things maybe come back and then restart at 10 milligrams. And then we lost track of her a little bit. So we had multiple phone interactions. She was going back and forth to out of state to take care of family issues, a lot of financial stress, wasn't doing the labs on time that we wanted. Finally reined her in about 2 weeks ago. This is 6 months into methimazole at 10 milligrams. And biochemically, not too bad, 1.2, 2.8 T4, T3 respectively, still subclinical hyperthyroid. So the TSH is less than 0.1, so still hyperthyroid on 10 milligrams. But she's more fatigued. Her goiter's a bit better, still shaky. But there's a lot of issues with consistency and adherence to therapy. Sometimes she didn't get her methimazole filled, so then she'd be without it for a week or two, and then get it filled. So there's a lot of back and forth trying to rein her in. And each stage in this, we said we have alternatives to antithyroid drugs in terms of surgery or radioactive iodine, and she very much was opposed to the concept of destroying her thyroid, and was happy with the idea of methimazole. So has been agreeable to try to be more consistent with appointments. So among some of the challenges, the initial presentation was a high-risk presentation, very large goiter, very high TRAb, T3 greater than the upper end of normal, very symptomatic. And she had a significant fluctuation in thyroid function test on methimazole, going from hyper to hypo, then back to a subclinical hyper. somewhat unreliable in terms of follow-up, and still a lot of anxiety and apprehension. And so she's, still clinically not very well. So, and still opposed to the concept of radioactive iodine. And she's getting a little bit of thyroid eye disease that makes me even less. I haven't given radioactive iodine for Graves in over 10 years, just to, as a disclosure. So I wouldn't give her radioactive iodine because she's developing eye disease, and not one who was interested in surgery either. So it's a clear challenge in trying to confidently and predictably, control her with antithyroid drugs.
Thanks, Mark. It's a very, very interesting case. We'll come back to some during the Q&A. I think probably some more questions about this case specifically. But before doing that, maybe Giuseppe, turn it over to you on the next slide. I think you have another case.
I have a case maybe simpler than this, but certainly exemplary. So 36-year-old woman was referred for hyperthyroidism. She showed up in the doctor's office with blood loss, tremors, anxiety, difficulty sleeping, and a rapid heartbeat. So those are typical signs and symptoms. And on exam, she was noted to have diffuse goiter. Of course, she was hyperthyroid, moderate hyperthyroidism, not very severe, but certainly very symptomatic. And a TSI of 328% clearly established a firm diagnosis of Graves' disease. There's no need for any other test. And when I saw her, I started, after having the conversation that I described before, I started her on methimazole 15 milligrams daily, which is nowadays my starting dose in people who are moderate for hyperthyroidism based on some study that suggests that that's a threshold for lesser side effects. And I also put on a beta blocker to control her tachycardia. And 6 weeks after initiation of methimazole, her thyroid function tests have come back almost into the normal range. TSH, as Mark is described, is still suppressed. It will stay suppressed for a little longer, but patient symptoms have greatly improved. She does report some mild palpebral edema and mild conjunctival injection that is starting. We stopped atenolol. She didn't need it anymore, and we continue methimazole 15 milligrams daily. They don't taper yet, just because she's not fully euthyroid yet. Her thyroid function tests are still borderline. But then just 2 weeks after I saw her in her follow-up, she calls me on the phone and she describes raised, very itchy, red pink bumps that come and go, and they're very disruptive to her daily life. She cannot sleep at night because she's continually scratching. And upon my suggestion, she stops the methimazole to see what happens. 3 weeks after discontinuation of methimazole, the free T4 and T3 are back in the high level, in the range, almost where she started from. They can return very quickly. No need to remeasure TSIs. She has hyperthyroidism, no question. The urticaria has resolved, but the symptoms have returned. And so the challenges presented by this case, which is not a very unusual case, we see, as I said, this in maybe 5% to 10% of people who take methimazole. The patient experienced this common side effects. And now she can continue the methimazole, but we have to talk about definitive treatment because that's the only alternatives we have. Radioactive iodine is undesirable. She has mild thyroid eye disease, and when I discuss it with her, I do still offer it to patients all the times. And but she said, well, if it's going to bulge my eyes, it's not going to happen. And then I told them about thyroidectomy, and she's concerned about becoming permanent, dependent on thyroid hormone, and she's concerned about the potential side effects or potential inefficacy of levothyroxine. And the hyperthyroidism, however, is still present. We need to do something about that. And that's basically the challenge that we sometimes face.
Great. Thanks for that. So, I mean, maybe if just to round out something that probably many people understand, but just to make sure we make the point strongly, the risk of radio ablation in the setting of some thyroid eye disease symptoms, Giuseppe, what's the issue there?
Well, so there are several studies that have shown a increased risk of worsening of thyroid eye disease in people who already have it. But there are also studies that shows the radioactive iodine precipitating thyroid eye disease in people who originally did not have signs of the thyroid eye disease. And the difficulty with those studies is that the actual prevalence, the actual numbers, the percent of that happening is not completely clear. It may be less common than we thought, but when the patient asks me the question, when does that happen? How often? I really have a hard time, based on the literature, giving them a straight answer, and that's a limitation that we have. And without that good answer, people really, really are afraid about that, and I cannot blame them. That's the most concerning, one of the most concerning conditions that we see in the thyroid field, to be honest. Very untreatable until recently, but it is really something that may change quality of life in a really difficult way to restore. So I do understand their concerns very well.
Yeah, yeah. And Mark, I know you made the point that you haven't recommended radioiodine in a long time. I think you have the advantage of a really good local surgeon. How do you counsel patients on the risk of surgery? And even in a center where you have an excellent surgeon, what do you feel patients need to take into consideration?
Right. So, we know from published literature that thyroidectomy for Graves' disease carries higher risk of complications than thyroidectomy for thyroid cancer or benign thyroid conditions. And that includes postoperative hematoma, a need for even tracheostomy. So these are things we don't usually talk about, but the data is there for those. Certainly a higher prevalence of postoperative hypoparathyroidism and recurrent laryngeal nerve damage. So it's important that the community, that if we're referring someone for surgery for Graves' disease, that we have a high volume surgeon. And I think that's where in an average community, if that's not there, then that makes that definitive treatment option, really difficult to suggest to a patient. So, having a thyroid dedicated surgeon, like we have here, makes it a more confident referral. So we exhaust our anti-thyroid drug options, and it's either adverse events like we've talked about, or just poor tolerance, or inconsistencies, or the patient's just tired of all the fluctuating levels and methimazole dose changes. Then we send them for surgery as our second line therapy. And this surgeon actually likes doing surgery for Graves' disease. So it works out well. But that's not the norm. That's why, the guidelines are very careful on recommending surgery, because not everyone has that high volume surgeon to work with.
Right. And thinking back to the ultrasound you showed, which showed that highly vascularized and enlarged thyroid, that's a very different situation than someone that just has a nodule, as you point out, whether that's malignant or benign. That's going to be a much simpler surgery than trying to remove a diffuse heterogeneous thyroid that's hot from so much Graves.
Correct.
Yeah. Excellent. So we started out with a pathophysiologic slide of Graves' disease and talked about the idea that the current standard of care really just is targeting the thyroid gland versus the root cause of Graves' disease, which is really more the immune system. So we are developing at Immunovant, a therapy that has potential to reduce antibodies and autoantibodies and may help patients with Graves' disease. We'll probably get into a little bit more of the nuances of the unmet need in the Q&A, but before we do that, maybe we'll go to the next slide to kick off our final poll question here. This is an open-ended question, so you can just add into the chat anything that comes to your mind, and we'll take a look at sort of the variety of answers we get here, and then have a discussion about that. Great, some good thoughts there and comments and questions. So I think, of course, the standard of care has a long history, and so the benefits and risks are very, very well described. Any new medicine is not going to have that advantage, and it will take some time to fully appreciate the benefits and risks of a new therapy. I think one of the things that was highlighted by a couple of the questions and comments is that non-compliance can play a role, and sometimes it's tricky to know. Giuseppe, you mentioned a patient who has been off their medicine, maybe deliberately, maybe accidentally, and then a week before their visit starts taking their medicine again. That's going to be they may not share that with you, so it's tricky to get as everyone who's treated patients knows to compliance in any area, Graves or otherwise. But I guess it highlights maybe the idea that anti-thyroid drugs they're challenging, I guess, to use for some patients. Some patients can get control with a steady dose and they don't have a problem taking their medicine every day, but other people struggle with the daily therapy and or have a narrow therapeutic window. And so, Mark, from your perspective, how much value is there in just having a medicine that's easier to take and has a wider therapeutic window, separate from the whole immunologic condition, which we'll get to in a second?
Right. I mean, that sounds like ideal. I mean, easier to take, more consistent, response, and a wide therapeutic window. So if we're, targeting the cause, the driving antibodies in Graves' disease, and then that's really what we need to do. The thyroid, as we've said, is innocent in this. So we're either slowing it down or we're destroying it. And so I think having something different makes a lot of sense, and something that it may help. I mean, there might be patients who have symptoms because of non-specific inflammation from this immune system response that we're really not addressing as thoroughly. So there might be some non-thyrotoxic benefit from lowering antibodies. So I think it's exciting to think after decades of having limited options, even though we've gotten better at using them, that we would have a new tool in our kit.
Yeah. One question here that is in sort of the general realm of what you're speaking about. I don't know how you feel about this. There's a question whether there's a role for a short course of steroids in some of these difficult cases, and whether you've ever used that and what's your experience.
Not specifically for the Graves' hyperthyroidism. I don't think there's any data to suggest that would work. And unless I think we know glucocorticoids don't do a great job for proptosis and diplopia. They might help with active inflammation in the short run, but then most of those patients will rebound. So I've not thrown on steroids for difficult Graves' hyper. I've only done that either years ago for before and after radioactive iodine, maybe to try to decrease the risk of radioactive iodine causing or aggravating underlying TED, or patients who have active thyroid eye disease, while I'm trying to look to bridge them to other options.
Yep, that makes sense. Giuseppe, there's a question here. What do you do for patients whose T3 and T4 have normalized, but whose TSH remains suppressed?
Well, to a certain extent, that depends on the age of the patient. That person has subclinical hyperthyroidism. And, in a younger person who does feel well, subclinical hyperthyroidism can be tolerated to a certain extent because it's not known to have untoward effects. In the person who is older, for example, a postmenopausal woman or any person who is older than 65, there are known risks from subclinical hyperthyroidism, and I will be a little more insistent on, for example, increasing the dose of methimazole if there is room for that, inquiring again about adherence because it would be unusual for that. And sometimes what you have to do, you have to push the methimazole until you make them slightly hypothyroid, and then you can cut back because sometimes you never know whether it's really the TSH that has been blocked and it doesn't return to normal just because it's been suppressed for so long. And making them hypothyroid for a few weeks or so will unblock that blockage, and then you can taper down the methimazole more confidently. So there are different ways to look at this. But again, age is a major factor in how, insistent you have to be in normalizing the TSH.
So some people you gotta wake up their pituitary, huh?
That's the theory. That's the theory. I don't know that we can prove it very well, but I do know that a suppressed TSH in a 65-year-old is not a good thing.
Yeah, yeah. And how long do you typically wait to before you're like, okay, let's assume compliance is off the table for the moment. Um, when would you expect the TSH to come up, and what's the range that you've seen? Like, how long before the TSH might start to normalize?
Start from very high thyroid hormone levels, and then, like in my case, after 6 weeks, those levels have normalized. The TSH is still suppressed. I'm not going to consider that a failure. I'm just going to stay the course and check levels again. Now, if the next time around the TSH is still suppressed and the thyroid hormones haven't decreased any further, then I do think that methimazole dose is insufficient. So I bring back the dose a little bit. But if the thyroid hormone levels have continued to fall, I expect in the next 6 weeks the TSH to climb. And so I don't rush it into titrating the methimazole too often. Otherwise, you end up biting your tail. You have to come back, and et cetera, et cetera. That's sometimes a part of the reasons why people get inconsistent results is because you change the therapy too often. And what happens,
Mhm.
you end up precipitating new hypertension, and you have to bring back. So you have to be uh, cautious in how often you do. But that's kind of my trend.
Yeah, yeah. Mark, Giuseppe mentioned using a little Synthroid to balance the patient who is kind of between methimazole doses. There's a slightly different question in the Q&A about block and replace as a strategy, which I interpret to mean, really heavy ATD and then Synthroid on top of that. I think it's popular in Europe. Is that something you've ever used? And what's your perspective on that, the literature that does or does not support it?
I think the initial literature seemed interesting, but I'm not sure the follow-up literature was that compelling. So like Giuseppe, I rarely use it. I think I have one patient on block and replace right now, but that's a very unique situation. So I've not used it. I rather just have patients fine tune, sometimes alternating 5 and 7.5 milligrams every other day of methimazole. So I tend to do that more than I would consider block and replace.
Yeah, yeah. I think that's very consistent with the U.S. perspective. Um, Giuseppe, there's another question about another supplemental medicine here, and that's selenium. Is that something you've ever used? And particularly, the question is whether you've seen any benefit in people who have a lot of evidence of autoimmunity with high TRAbs, maybe also TPO antibodies and things like that.
But the short answer is no. I haven't seen any solid evidence that selenium does anything to traps. There are some soft evidence studies that show some efficacy in decreasing the titer of TPO antibodies, but I don't know what to make of that. I mean, I don't think the TPO antibodies are ever a target of treatment in any way. So I don't think that that's a very viable supplement. There is data on thyroid eye disease that it's separate, which is also, questionable because it is deriving from areas with selenium deficiency, which we don't have in the United States. So I do recommend it with thyroid eye disease, but I am skeptical.
Yeah. Great. Let's end with a clinical question here, and that is, what tricks or tips do you have for quantifying the weight of the thyroid on physical exam? Mark, you
For
want to take a stab at
for
that?
on physical exam to try to guess.
Right, right. Yeah,
Yeah,
maybe you just go to ultrasound,
I cheat. I have an ultrasound. So but if I were to think about a normal thyroid being 10 or 15 grams and usually not visible, if I can see a thyroid, then it's probably 2 to 3 times normal. And then you certainly try to feel the thyroid. We used to use a piece of paper and a pencil and trace the thyroid, for these big goiters. And then you can, measure that and then begin to do some volumetric math. Of course, you're not getting the depth, but you get an approximate, goiter size that way. We did that with nodules as well before we had ultrasound and training.
Yeah. How about you, Giuseppe, using any physical exam tricks or primarily ultrasound?
Well, I do roughly guesstimate the size of the gland in terms of times the normal size. I don't fool myself in thinking that I can estimate the weight in grams with my thumbs. I don't think so. But I do measure the volume sometimes with ultrasound, especially when I'm planning on radioactive iodine. I try to use the weight to calculate the amount of radioactive iodine. And I think the most objective way to do that is with an ultrasound. Even that is imprecise, but it's certainly better than my thumbs for sure.
Yeah, very good. Excellent. Well, it's been a really fun discussion. Giuseppe and Mark, I really appreciate you joining me and also preparing the cases in advance, which were instructive and I think really aided the discussion. For our participants, there's a QR code now on the screen. If you don't mind using your phone to open that up, it'll take you to a very simple survey that'll give us some feedback on the webinar today and allow us to understand which parts were really valuable for you and if there are anything that we would need to improve or change for future iterations of this webinar. So thanks again, Giuseppe. Thanks again, Mark. Hope you guys have a great evening.
Thanks, Pete. Nice to
Thank you, Peter.
Bye-bye.
Bye-bye.
Bye.
Bye.